Good afternoon. My name is Dr. Ibiayi Dagogo-Jack, and it's my pleasure today to present on lung cancer risk factors. These are my disclosures. So in this 20-minute talk, the objectives are to discuss the current understanding of risk factors for lung cancer. And I recognize that it's difficult to comprehensively delve into all the risk factors for lung cancer in this short amount of time. So I've instead chosen to focus on a couple of key aspects, specifically established environmental risk factors, some emerging genetic associations, and then special populations that I think it's worth highlighting, because these are patients who are underappreciated in terms of the risk of lung cancer, which may lead to downstream delays in diagnosis. And so, as many of you know, lung cancer is a very common disease. It ranks only after breast cancer and prostate cancer, and basically in cancer incidence. It's estimated that in the United States this year, 230,000 people will be diagnosed with lung cancer. This is nearly evenly split between males and females. And as far as lifetime risk, when we think about males, there's from birth to death, there's a 1 in 15 chance of developing lung cancer. And for females, it's a 1 in 17. So this just highlights how prevalent this disease is. While breast and prostate cancer outnumber lung cancer in terms of incidence, lung cancer is by far the leading cause of cancer-related mortality in the United States and worldwide. It accounts for nearly a quarter of cancer-related mortality in males and females. And it's estimated that this year, 130,000 people in the United States will pass away from lung cancer. And so this just highlights that this is a devastating disease where early detection and prevention strategies are key, and improving our therapeutic arsenal is imperative. And there's been considerable efforts over the years, and many of which are ongoing, to try to evaluate whether or not the burden shouldered by patients with lung cancer is disparate, or there are disparities in the burden of lung cancer incidence rates as well as mortality rates for different racial and ethnic populations. So this slide looks at the same data we just looked at, but focuses on patients, Black patients. And when we look at these data, we see similar trends. So lung cancer is the second leading cause of cancer in both males and females, and it's outnumbered by breast and prostate, but it's still the leading cause of cancer-related mortality. When we look at these data and summarize other data, we find that the relative rate of developing lung cancer is higher in Black men than white men, and the converse is true for women, where there's lower rates of lung cancer in Black women compared to white women. And it's thought, there's many factors that could contribute to that, but at least in women, it's thought that smoking habits or differences in smoking habits may underlie these differences. And when we think about death rates or mortality from lung cancer, I think that this is something that's best appreciated by looking at trends over time rather than looking at static data. And so if you focus on the middle panel and the final panel, this is looking at lung cancer death rates over time between 1990 and 2015. Before we look at this, it's important to put it in context. So between 1950 and 1990, there was a sharp increase or steep increase in the rate of lung cancer as well as other cancers among African Americans, as well as the mortality related to this. And it outpaced Caucasians. But as we look in more recent years at these two curves, we see that there's a convergence of the curve with basically the Black to white ratio in terms of mortality. The disparity is narrowing. I present these data not to say that no disparities exist. Rather, if you actually look at the first panel, which is of the bar graph, which is looking at kind of stage by stage 5-year survival rates, we see that there's still disparities, particularly among patients who are diagnosed with what we consider curative lung cancer, localized or regional disease. And there's a lot of investigation in this area to figure out whether this reflects inequities in access to care, or whether this is a reflection of the therapies that are offered. And I highlight these data, and some might be asking, why is this kind of in a talk about risk factors for lung cancer? So we don't think of this as a traditional risk factor for lung cancer, but I do think it's worth noting that socioeconomic factors and race can be risk factors for having particularly adverse outcomes from lung cancer. Now shifting towards traditional risk factors for lung cancer, tobacco smoking is the #1 risk factor for lung cancer. but it's worth emphasizing that not all lung cancer is associated with cigarette smoking. It's estimated that among men, 90% of lung cancers are attributable to cigarette smoking, and in women, that number is a little bit lower at 75 to 85%. And so there's different ways one could interpret that statement, but I think one takeaway should be that there's a sizable subset of patients who will develop lung cancer without a smoking history. And these data are from the United States, but when we look across different geographical areas and look across the world, the prevalence of lung cancer among never smokers, particularly never smoking women, can exceed 30% in some populations in Asia. But I think it's important to note that smoking is the predominant risk factor for lung cancer, and recognizing that, it's encouraging that the prevalence of smoking has been decreasing over time, as you can see from this graph here. And it's not enough to say that smoking increases the risk of lung cancer and mortality from lung cancer, but I think it's important to also dive into the data. So we know that the number of cigarettes you smoke and how long you smoke impacts the relative risk of developing lung cancer. So this is a study from Thune and colleagues that was published in New England Journal in 2013. It was a very interesting analysis and a large-scale data set, basically nearly 1 million patients between 3 different data sets between 1960s, the 1980s, and what they call a contemporary cohort, which pooled 5 studies spanning from 2000 to 2010. And what these data showed is that compared to never smokers, current smokers, or people, specifically people who had a 40-pack year smoking history, had a 20 times increased risk of developing lung cancer and kind of having mortality from lung cancer. But when we look at these graphs presented here from the contemporary cohort, and we look according to cigarettes per day in men and women, we see that there's nearly a tripling of the relative risk of developing lung cancer for people who smoke more than 40 cigarettes a day, which is a substantial amount compared to people who smoke less than 10 cigarettes per day. And what this graph also conveys is how timing of smoking cessation modulates risk of developing lung cancer. We see that for people in both cohorts, in both groups, people who quit smoking before age 40 had a dramatic reduction in the relative risk of developing lung cancer. And this finding has been seen across studies using similarly large cohorts. This graph here represents findings from the 1 million women UK study. In this study, they enrolled women, it's an observational study, they enrolled women in their 50s and 60s and followed them for health outcomes and disease outcomes. This particular analysis was looking at the rate of lung cancer among never smokers, current smokers, and former smokers, and breaking down the current smokers by the time that they quit smoking. The dashed line or the dotted line at the bottom is never smokers, and then the relative risks that are presented are the relative risks of lung cancer-related mortality. We see that people who's on the far side, people who quit smoking in their 50s, had a nearly 6-fold increased risk of dying from lung cancer, and that was decreased to 1.56 when people quit smoking before their mid-20s or so. And this finding is mirrored to some degree in another study of British males, and this was a physician-based study that was launched in the 1950s when smoking was still, when the prevalence of smoking was much higher. And here we see that when we calculate the cumulative risk of lung cancer by age 75, it decreases for those who stop smoking earlier to 2 to 3% from 10% for people who quit smoking later in life. So people who quit smoking around age 60. And so collectively, all of these data suggest that smoking cessation significantly, particularly the timing of smoking cessation, can impact the relative risk of developing lung cancer and mortality from lung cancer. It's estimated that over 90% of the excess risk or excess mortality from lung cancer, from cigarette smoking, can be avoided by quitting smoking before age 40, and quitting smoking before age 30 can reduce that even further. And so this suggests that we should be doing all that we can to encourage our patients to quit smoking and implementing smoking cessation programming. But I recognize that it's challenging for people to stop smoking. And this has kind of led to the research question, or fueled the research question. can we still improve outcomes by having people just cut back on how much they're smoking? And so this is a data set, a Dutch data set of 19,000 patients, where they asked this exact question. They compared the incidence of lung cancer for patients who were heavy smokers, defined as greater than 20 cigarettes a day, compared to those who cut back on smoking, so less than 10 cigarettes a day. And they observed a 27% reduction in lung cancer risk just by cutting back on smoking. And to me, this is somewhat encouraging in that it tells us that we don't have to go from 100 to 0%, but perhaps we can go to an intermediate level as an initial step, as a bridge to quitting smoking altogether. And so we should still, instead of giving up on smoking cessation efforts, we should encourage at least reduction in the tobacco intake with the hopes of getting people to cease smoking altogether. And these data were pertaining to active smoking, but there is a phenomenon that we're all familiar with called passive smoking or secondhand smoking. I will admit that this is the risk of lung cancer from secondhand smoking is less robustly characterized. And that's because it's tough to quantify how much secondhand smoke someone is exposed to. However, meta-analyses suggest that there's basically the odds ratio of developing lung cancer is 1.2 to 1.3 for people who are exposed to secondhand smoke, either through environmental, so spouses who smoke in the house, or occupational exposures. I present this article here because I think it's interesting in that it's looking at secondhand smoke in general. Yes, how it contributes to developing lung cancer, but also fatalities worldwide. And in this analysis, they attributed 1% of deaths worldwide to secondhand smoke, and estimated that in 2004, so nearly a decade ago, but I imagine that the data still applied to this time period, that over 20,000 deaths were attributable to lung cancer deaths were attributable to secondhand smoke. And as we see from the bar graphs here, that a lot of this is shouldered by women. And recognizing that smoking is such a driving factor for developing lung cancer, and recognizing importantly as well that diagnosing lung cancer at early stages is important. It's crucial for curing lung cancers. There's been basically fueling of strategies to improve early detection of lung cancer, and one of the ones that has gained the most traction is Lowdose CT screening. And presented on this slide are a series of studies conducted mainly in the United States and in Europe, comparing low-dose CT screening to chest X-ray or usual care. As you can see, these studies vary in terms of the criteria for screening, as well as the number of patients in these studies. I wanted to highlight two of them. The first is the NLST study, which many of you may be familiar with. It was published this year, but presented earlier. And this is a European study that enrolled 15,000 people, mainly men, so 13,000 of them were men, and randomized patients to no screening versus CT screening at baseline, year 1, year 3, and year 5.5. What this study found was that at 10 years, among men, there's a 24% reduction in lung cancer-related mortality with screening, and this number was even higher in women, so 33% reduction in lung cancer-related mortality. This study echoed findings from the NLST study published nearly a decade before this. The NLST study, which many of you may be familiar with, is a United States-based study, and which enrolled approximately 50,000 patients. Patients had to be between ages 55 to 74, have smoked at least 30 pack years, and be current smokers or quit within 15 years. Here, patients were randomized to annual screening for 3 years with either a CT scan, low-dose CT, or chest X-ray. This study found that, similar to the NLST study, that there was an overwhelming advantage to CT screening with a 20% reduction in mortality from lung cancer. Importantly, 60% of detected lung cancers were stage 1 or 2. This is what we hope for. You hope that you're finding early stage lung cancers. And so those studies demonstrate, that screening saves lives. And if we cannot, prevent smoking, the uptake of smoking, we certainly should be increasing our screening practices, recognizing that this is a significant risk factor for lung cancer. As far as other risk factors that are not smoking, asbestos exposure is one that comes up quite often. I want to pause for a second and mention radon. I'm not discussing that in this talk. There's conflicting data in terms of the influence of or impact of radon exposure on lung cancer risk. I think it's intriguing data, but for the sake of time, I focused on a few key ones, including asbestos. And so there are data, perhaps stronger than the radon data, that suggests an association between asbestos exposure and lung cancer risk. I've presented one study here. This is a large data set comparing men with occupational exposure to asbestos. So these men are insulators. There's approximately 2,400 of them compared to a peer cohort of over 50,000 non-asbestos exposed males, which they basically termed blue-collar professionals. And so when we look at these data, starting with this graph over here, CPS2, when we look among non-smokers first, CPS2 is basically the comparator cohort of people who were not exposed to asbestos. We see that there is a 5-fold increase in lung cancer incidence or lung cancer risk for people exposed to asbestos. And the risk is even higher for people who have imaging findings suggestive of asbestosis, like pleural plaques. When we look among smokers, even smokers, not surprisingly, smokers who don't have asbestos exposure have an increased risk of lung cancer compared to those who have smoked have an increased risk of lung cancer compared to those who have never smoked. But that risk is significantly higher when you combine smoking and asbestos exposure. So 30 to 40-fold higher than never smokers who are not exposed to asbestos. There's a lot of work trying to tease out exactly what the interaction between asbestos and cigarette smoking and how these impact development of lung cancer. And the questions have been whether or not this is a kind of additive effect or multiplicative effect. And the jury is still out, but there is some suggestion based on tracking the prevalence of lung cancer among people who have quit smoking but have been exposed to asbestos that suggests that the prevalence or incidence of lung cancer among these cohorts exceeds what you would expect just from an additive association. And so for now, it's thought to be super additive, but not quite multiplicative. And now to turn towards, I think, in what I personally think is an intriguing area, and that is a genetic predisposition to develop lung cancer. So this work dates back kind of decades, and initially it focused on GWAS studies or genome-wide association studies where they were looking for potential susceptibility loci that were enriched in people who had lung cancer versus those who did not. And those studies are hard because there's inconsistencies across studies. So I think some of the more intriguing data have emerged in recent years where people have studied families where there's multiple family members across generations who develop lung cancer and done germline sequencing as well as somatic sequencing of tumors and demonstrated that there are certain mutations in key oncogenes like EGFR and HER2 that are enriched or that are in every single blood cell for these family members and also seen in the tumor cells. Perhaps one of the earliest ones described was EGFR T790M. Those in the lung cancer field may be familiar with this mutation. It's something we associate with resistance to targeted therapy, but it is something that can arise de novo or without intervention, without treatment. And interestingly, it doesn't drive kinase activity. It doesn't drive lung cancer enough on its own. And so many of these patients will end up having a second hit. Like in this family in the first image, where multiple family members had lung cancer, but many of them had a second EGFR mutation on top of T790M. One patient L858R, the other G719A. In the second example, it's a different EGFR mutation, a different family that had basically multiple family members with lung cancer, many of whom had not smoked. And we see a V843I mutation in all of these patients, but those who developed lung cancer also had an L858R EGFR mutation. So this is still an emerging science, and it takes identifying these patients, working with our genetic counselors and our genetic teams to figure out the best strategies for these patients and to be able to tease out kind of associations, key associations between these mutations and causality of developing lung cancer. EGFR is not the whole story, so there's emerging analyses suggesting that HER2, particularly this C660D mutation, can also predispose to developing lung cancer. And I think that on this, in some ways, on this theme of kind of lung cancer that emerges outside of smoking, I wanted to highlight two patients of mine, actually, because I think this is an underappreciated area: lung cancers in teenagers and young adults. The first is an 18-year-old who presented with cough, shortness of breath, and eventually started to cough up blood. He was seen by his primary care provider and other doctors and given antibiotics, treated for asthma, and for many months before they finally did imaging and biopsying that demonstrated that he had widely disseminated lung cancer. The second is a 30-year-old who had headaches and cough. He was treated for migraines and pneumonia until eventually he got imaging that showed that he had metastatic lung cancer. Both of these patients had tumors without rearrangement. And so we are starting to appreciate that there are very, very young patients who are diagnosed with lung cancer. And it's been noted that there's enrichment of driver alterations or actionable mutations and fusions in these patients. This is an analysis by Satcher and colleagues that looked at the prevalence of certain mutations and fusions in tumors from patients divided by age of onset. We see that compared to patients who were over 70 when they're diagnosed, those that were less than 40 years old, the majority of them had a actionable molecular alteration. And this is even before kind of the last 2 years where we've actually characterized and developed therapies to target even more alterations, even more genes. And so one can imagine that that 50% might be even higher now. There's been elegant analyses using computational algorithms and whole exome sequencing that have been performed to try to tease out when these alterations are acquired, when in someone's lifetime they acquire these alterations. One of them suggested that at least in 2 patients who had fusion-driven lung cancer, that they actually acquired these lung cancer-causing fusions early in life, estimated one at age 14 and one at age 1. They didn't actually, not my 2 patients, these are different patients, but they didn't actually develop lung cancer until they're in their 50s. So this suggests that it's not enough to just have these genes. There must be other factors that happen downstream that lead to overt lung cancers. And the fact that people can have the same alteration and have lung cancer at age 18 versus some people who develop it at age 50 means that we still have our work cut out in terms of figuring out what are the factors that drive lung cancer in these populations. And many of these patients, these young patients with lung cancer, have limited or minimal smoking history. And so they're encompassed in a broader group of patients that we think of as kind of never or limited smokers who have lung cancer. This is an emerging kind of increasingly recognized subset. And I think that's through kind of increasing adoption of molecular testing, but also honestly through advocacy from patients themselves and forming of these patient groups for patients who have similar molecular tumors with similar molecular background. I think this is an incredible asset to the field. A little bit about these types of cancers. In general, they tend to be adenocarcinomas, but not always. And so we shouldn't generalize. I think it's still worth testing if you have a never smoker with lung cancer or minimal smoker with lung cancer, and all comers with lung cancer, frankly, for molecular alterations. As you saw in the previous slides, there's enrichment for actionable alterations in these patients, not only in younger patients, but also in never smokers with lung cancer. We think that over 50 to 60% of them will have an actionable alteration. There's some data suggesting that certain alterations, like for example, an EGFR mutation, can be enriched in people who are basically women or people from different parts of the world. And we're still trying to sort out whether or not how kind of occupational and environmental factors impact or influence the risk of developing lung cancer in these never smokers. There is some association between radiation exposure and thyroid cancers that are driven by fusions. And so there's work looking at whether or not that's the case with lung cancer. So this is a very active area of research that we need to stay tuned for. So in summary, 2 key points and 2 different populations. One, Smoking is the predominant risk factor for lung cancer. We know that smoking cessation prior to age 40 dramatically reduces lung cancer risk. And we know that screening saves lives. And so action items would be to increase adherence to lung cancer screening. We know that, low-dose CT screening is imperfect, but it's what we have. But we need to work diligently to develop alternative strategies for early detection of lung cancer, whether it's blood-based assays, methylation assays, and other platforms. I think it's equally important in the same way that we invest in genotyping tumors and developing new therapeutics for our patients to invest in smoking cessation initiatives, because we know that particularly among youth and young adults, getting people to quit smoking early can significantly and dramatically reduce the risk of developing subsequent lung cancers. And for the second population, we know that there's a minority, but it's an important minority of patients who develop lung cancer without known environmental exposures or smoking history. We know that this type of lung cancer is enriched for molecular alterations, but that's about all we know, right? We don't know what the factors in foster development of lung cancer in these patients. And I think that there's immediate action items and downstream action items. Immediately, we can work to educate our PCPs, ED providers, those at the point of access to care, to increase awareness of this type of lung cancer and to facilitate timely diagnoses. In parallel, we should be working with epidemiologists, scientists, our patient groups to try to characterize and kind of elucidate the factors that predispose to this type of lung cancer. And finally, these patients aren't really captured in our current screening practices and our current screening guidances. So we need to develop more inclusive screening strategies that to help us to more broadly capture patients who have early stage lung cancers and patients at risk for lung cancer. Thank you for your time.